Left ventricular hypertrophy is a common finding in echocardiography, but there's more to hypertrophy than just measuring the thickness of the septum. I would like to show you the physiology behind hypertrophy, the importance behind it, how to measure it, and of course what the clinical importance of this finding really is. There is no question that hypertension is the most common cause for left ventricular hypertrophy. And we know that hypertension is a very frequent finding. Approximately 25%, so a quarter of the population in the Western world, have hypertension. Arterial hypertension is an important risk factor. Thus, hypertension has been incorporated into all risk scales. The prevalence of left ventricular hypertrophy varies depending on the method of measurement and also on the study population, but it has been proposed that it lies somewhere between 10 and 60%. So again, a very common finding. Left ventricular hypertrophy increases mortality. An increase of 50 grams per square meter increases the risk by 1.73. The pathophysiology of left ventricular hypertrophy is at least partially clear. We know that it is a response to elevated left ventricular afterload, which is caused by an elevation in blood pressure. So very similar to a skeletal muscle which increases its thick, which hypertrophies in response to exercise, the heart muscle also hypertrophies, but this time pathologically in response to an elevated afterload. However, there are also a number of other factors which are involved, such as obesity, neurohumoral factors, especially norepinephrine and the renin-angiotensin system, age, and sodium intake. Again, I just want to draw your attention to the relationship between systolic function and left ventricular size, in particular in patients who have small ventricles, as we see them in the remodeled type of concentric hypertrophy and hypertension. A normal-sized left ventricle does not have to decrease the size of the left ventricle to the same degree as a small ventricle to eject the same amounts of blood. In other words, the small left ventricle will always appear to be more hyperdynamic even if you inject the same amounts of blood as a normal ventricle. Let's take a look at such an example. This is a small left ventricle with almost complete obliteration of the cavum of the left ventricle. There has to be hyperdynamic function because the ventricle is so small, and thereby the left ventricular function appears to be hyperdynamic. Another issue which is important, patients with hypertrophic small left ventricles, as I already showed, appear to have hyperdynamic function in the radial direction specifically, but these patients very often already show deterioration of longitudinal function. We can measure that with specific techniques, such as the speckle tracking technique, where we measure deformation parameters which also show us how the longitudinal contraction is. This is such an example which shows us that there is already a decrease in longitudinal function, especially in the basal segments of the ventricle. In other words, very often these patients who appear to be hyperdynamic already have some form of discrete or subclinical systolic dysfunction. The Laplace rule states that there is a relationship between the afterload or the strain on the left ventricle and wall thickness, the end diastolic diameter, and the blood pressure. If the wall thickness goes up, we have a decrease in afterload. So this also explains why there is left ventricular hypertrophy. It's a compensatory mechanism. If the end diastolic diameter goes down, we have a decrease in the afterload. And obviously, if blood pressure drops, the strain on the left ventricle and the afterload is also less. Now let's take a look at a few examples. This is a normal ventricle. We have normal size, we have normal mass, normal relative wall thickness, normal systolic stress, and also normal systolic shortening. So a completely normal left ventricle. In comparison now, a concentrically hypertrophied left ventricle. Note that the ventricle is much smaller, the mass is elevated, and because the ventricle is smaller, we have an elevation in the relative wall thickness. Depending on many factors, we can have either a normal or reduced systolic stress or a normal or elevated systolic shortening in these patients. Remember, we have hyperdynamic function in small left ventricles. This is a concentric type of left ventricular hypertrophy. We have now a normal-sized left ventricle. It's not smaller than normal, but normal. The mass is obviously still elevated, and the relative wall thickness again becomes normal because we now have an increase in the left ventricular size. The systolic stress again depends on many other factors and can be elevated, decreased, or normal in these patients. And the systolic shortening is usually normal or maybe mildly elevated depending on the size of the left ventricle. Now this is an example of an eccentric left ventricular hypertrophy. In this case, the left ventricle is dilated, the size is enlarged. This was a patient who had volume overload because of aortic regurgitation. The mass is elevated. Even this might not be apparent if you just measure the thickness of the myocardium, of the septum. But if you take this heart and you put them on a scale, you will find that it weighs more than a normal heart. The relative wall thickness is reduced. Systolic stress depends on other factors as well, such as preload and afterload. And systolic shortening can be normal or elevated depending on other factors. And in conclusion, I want to show you a patient with a dilated cardiomyopathy. Again, the size is dilated, the mass is elevated, relative wall thickness is elevated, systolic stress can be very variable, and systolic shortening is reduced. So all of these patients I showed you, with the exception of the first patient who had a normal heart, have left ventricular hypertrophy, but they all have different forms of left ventricular hypertrophy and different stages of hypertrophy and also different causes. And you can differentiate these causes just simply by looking at these factors, the size and the relative wall thickness. Now that we talked about the basics of left ventricular hypertrophy, let's take a look at how echocardiography can help us in various clinical situations.